Okay, first, thank you for coming out on this sort of dreary, cold, windy evening, but we're glad that you did. We were looking forward to the fact that you would. So, good evening. I'm Linwood Cousins, professor in the School of Social Work and director of the University Community Empowerment Center here in the College of Health and Human Services. On behalf of Dean Early Washington, it is my pleasure to welcome you to the Burian University Community Lecture, featuring Dr. LaQuandra S. Nesbitt, a board-certified family physician, and among her many other credentials and qualifications, an expert in public health policy, planning, and evaluation. The Burian University Community Lecture Series honors the memory of Dr. Bill Burian, the first dean of the College of Health and Human Services at Western Michigan University. Dr. Burian was known as a person of great foresight and vision. He was a distinguished scholar, researcher, educator, and community service activist, and was well known for his many leadership roles at a national, state, and local level. We also have the pleasure of having present with us his wife, Mrs. Ann Burian. Let me ask you to please stand. Mrs. Ann Burian. Thank you and welcome. Bill Burian endowed lectures bringing together students, faculty, community professionals, service providers, and citizens to focus on community and educational issues in health and human services from a problem-solving perspective. As such, I'm sure Dr. Burian would be pleased to see all of you here this evening with our distinguished speaker to learn about successful strategies for interdisciplinary collaboratives to achieve health equity. Dr. Burian would also be pleased that this lecture is a collaborative effort with the college's Committee on Diversity and Inclusion and an introduction to that committee's second biennial health equity conference called Collaboration for Equity, Building a Community that Supports Health Care for All, which is tomorrow. That conference occurring tomorrow will be hopefully attended by many of you. Hopefully all of you plan to attend. Okay. This lecture and the conference are indeed expressions of the values of Dr. Burian, the college, and the university. Among those values are support of a comprehensive service system that is responsible to all citizens and a commitment to foster interprofessional education and experiences like this lecture. Indeed, I know that many disciplines are represented here, as well as students, community members, and others. We're going to ask, as Dean Washington normally does, a show of hands for each of the different departments and schools in the college. So I'll ask that the Department of Blindness and Low Vision, if you will indicate your presence by a show of hands. Blindness and low vision. Okay. How about Health Informatics and Information Management? Okay, great. Integrative Holistic Health and Wellness. Great. Information Technology Services. Right. Interdisciplinary, the School of Interdisciplinary Health Programs. Great. Interdisciplinary Health Services. Okay. The Interdisciplinary Health Services PhD program. Great. The School of Nursing. Okay. Department of Occupational Therapy. Great. Department of Physician's Assistant. Okay. School of Social Work. All right. And the Specialty Program in Alcohol and Drug Abuse. And finally, the Department of Speech Pathology and Audiology. I'd also like to welcome participants from West Med, or the medical school here at Western Michigan University. If you were here from medical school, thank you. Okay. Again, welcome to all of you and to Dr. Nesbitt. Let me begin my introduction of her by saying making a few additional comments. And first, is that I met Dr. Nesbitt, and I was sure she didn't remember me because she's met hundreds and hundreds of people. But during my my fellowship, American Council on Education Fellowship at the University of Louisville, I spent quite a bit of time with the Vice President for Community Outreach or Community Engagement, Mr. Dan Hall. And many of the events that Dan went to, I was allowed to accompany him. And Dr. Nesbitt was at a couple of those events with the mayor of the city and others, where she spoke eloquently, powerfully, clearly, and thoughtfully about issues related to public health, issues related to health disparity, and in general tied all of those things together in a way that helped us understand better the well-being of citizens in Louisville and in Kentucky at the time. So I immediately, when I was asked to share some of my thoughts about a speaker for the lecture this evening, I thought of Dr. Nesbitt, and we're very fortunate that she accepted the invitation. Not only are we very fortunate that Dr. Nesbitt is able and willing to be here, but that she comes to us having taken very recently the position of the director of the District of Columbia Department of Public Health. This is after serving as director of the Louisville, Kentucky Metro Department of Public Health and Wellness since July 2011, a position in which she accomplished much and continued a career of distinguished service and scholarship. During her tenure as health director in Louisville, Dr. Nesbitt established the Center for Health Equity, which aims to achieve equity in the social determinants of health throughout Metro Louisville using a health in all policies approach. There, she focused on a commitment to 5 strategic priorities, the results of which included release of the first Metro Louisville Health Equity Report, establishment of the Mayor's Healthy Hometown Leadership Team, along with expansion of that movement to include tobacco prevention and control and chronic disease prevention and management, and development of public-private partnerships to implement the Centers for Disease Control and Prevention's Community Transformation Grant Program. In addition to being a skilled administrator, Dr. Nesbitt is also a primary care provider, a teacher, a volunteer leader, a scholar, a researcher, and a published author. She served as executive editor of Population Health, Management, Policy, and Technology, first edition, and her academic interests include racial and ethnic disparities in health outcomes, healthcare services, workforce diversity, and improving access to care for the uninsured and underinsured through population health management, policy, and health services research. Dr. Nesbitt finally received her Bachelor's of Science degree in biochemistry from the University of Michigan in Ann Arbor, her medical degree from Wayne State University School of Medicine, and a Master's of Public Health in Healthcare Management and Policy from Harvard School of Public Health. Dr. Nesbitt completed an internship in family medicine at the University Hospitals of Cleveland, Case Western Reserve University, and Dr. Nesbitt completed her family medicine residency in the University of Maryland's Department of Family Medicine, where she also served as chief resident. Dr. Nesbitt completed finally her fellowship training with the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. We look forward to her contributions in Washington, D.C., and we look forward to her lecture this evening. Please join me in welcoming Dr. Nesbitt.
So we're going to get everything turned on and then sort of give you guys the rules. So my first rule is that my goal is not necessarily to get through all of my slides. My goal is to answer your questions, okay? So if there's anything that I mention that you want clarity on, please feel free to ask for that clarity, okay? So I'm not going to yell at you and say, no, please hold your questions until the end, because I have 17 more slides. is that's not an effective strategy. The second one is that I make sure to leave time for Q&A, because when we have fancy titles and long titles for our presentations, everybody comes with the expectation that we're going to talk about something specifically. So I use time for Q&A, because if I don't talk about what you want me to talk about, then that's your opportunity to make me talk about what it is you intended for me to speak about. So those are the two basic rules for this evening. Does that work for everybody? Okay. So now we'll move into the presentation. This is my disclaimer. I have worked for a lot of people, hopefully will work for more people in the future. And so these presentations are my own professional and at times personal views and perspectives, and are not those of my employer. So don't call them tomorrow and tell them that they have some kind of position on something, okay? These are my professional and personal views and perspectives that I am sharing with you to help advance your work and how you're going to care for the people of Kalamazoo City, County, and any place that some of you students may ultimately land and beyond, so we can improve the health of our country one community at a time. All right, so here's the agenda. This is what we're going to talk about over the course of the evening. So for common ground, I'm going to use some terms, and I want to make sure that you all understand the definition of those terms, because I will use them. You may think I'm using them interchangeably, but I'm not. So when I'm talking about health, I like to use this definition. And it's important that you all understand why I like to use this definition. It's not just because it's the World Health Organization's definition. I use this definition because it allows me to have a seat at any table I want to. Okay? This definition includes social well-being. Okay? That means just about anything in a society. So anything that people are having a discussion about, education, economic opportunities, income, all of that is social well-being. So that is all intimately related to health. So I can participate in all of those conversations. Typically, if you're thinking about just the absence of disease, you're not invited to the party. But if you use this definition of health, which encompasses social well-being, you get to be part of those discussions. It'll be very important when we start having a conversation about health equity. Typically, when people talk about health, we tend to measure it around these concepts or use these terms: morbidity, which is how sick we are; mortality, how we die; quality of life, what experience we're having while we're living; and then life expectancy. That's the big one. If people say, well, what's one thing we could do to talk about how well a community is? How long do we live? So we've had advances or lengthened the life expectancy of people in the United States because we've improved communicable diseases, things of that nature. But now we're hearing, you know, this is going to be the first generation that doesn't live as long as its parents because we've got some other issues going on. And we'll talk about that because many of those are rooted in health inequities. Now, public health, one of the fields that I'm professionally trained in. Preventing disease, prolonging life, and promoting health. It's actually a science, okay? It's not a governmental agency. That's often what people think about when you say the term public health. It's like a governmental agency that provides health care for poor people and inspects restaurants. It's actually a science. It's a field of study, okay? Now, it happens to perform those functions often in a local governmental capacity or as a state agency, but it's actually a science, and it informs choices of society organizations, public and private, et cetera. So it's not limited to some building owned by the government and where bureaucrats process documents that you get your birth certificate and things of that nature, okay? So again, it's very important that we think about our definitions. Now, in this country, the public health folks have met. We've decided that we have core functions and essential services, and that's what this nice little pretty wheel is. So when you hear people who work in governmental public health and they're talking about this is what we do, this is what we stand for, this is the kind of language that they're using, okay? So these are the three core functions: assessment, policy development, and assurance. If you all are trying to engage with your health department at the local level or the state level, it's important that you know how they think. These are their core functions and 10 essential services. I am showing you this for a reason. I can email it out to you all, and you'll have access to the slides. Nothing is proprietary. Except one thing in here, people keep telling me I need to trademark. I think that might be tomorrow morning. Okay, so framework for public health and equity. Now, this slide helps us to think about for the rest of the time together today, and for those of you hopefully who will show up tomorrow morning, you'll see this again. So if you miss something tonight, we'll re-emphasize it tomorrow. Part of the challenge with improving the health of our society is that we tend to think in what we call downstream. We tend to think about once people get sick, or if you are a data person, we tend to think about, oh my God, we have high death rates of X. We have high cancer death rates. What are we going to do about high cancer death rates? What are we going to do about shortened life expectancy? And then we start thinking about, oh, well, we have high cancer death rates, which gets us in the disease and injury space. Oh, well, why do we have high cancer death rates? Oh, because people smoke, which gets us into risk behaviors. Or because people eat too much, certain trans fats. Or people barbecue, and they're getting exposed to, we have this conversation over and over again about the nitrosamines and all of these things, and we're really trying to get down to the nitty-gritty about the cancer pieces. So all of those things are downstream. It has to do with healthcare access. Are people getting the cancer screenings when they should? Do people have the health knowledge to understand that if you smoke, you're putting yourself at increased risk for cancer? Are people genetically predisposed to cancer? Do they have breast cancer genes? Okay? All of those things are what we call downstream approaches. Part of the challenge is when we only focus on that, which is part of a medical model, we're not really going to improve the health status of our community because we're completely ignoring the things that are upstream, which is the equity piece. Okay? The equity piece means that we have to think about, why do people smoke? What are the parts of their social and economic environments and situations that have driven them to smoke? Why do cigarettes cost so little in certain neighborhoods or certain states? Are there certain things related to stress that cause people to smoke? Is there something associated with nicotine that releases something, that does something in your brain? What is the part of addiction? What are people using as a coping mechanism, okay? So you have to start beginning to deal with that. What is it? Is there something about institutional racism? What about the neighborhood composition? All of those things are part of upstream, part of what we call the socioeconomic factors, are part of socio-ecologic models. Are you all familiar with that term? Socio-ecological models, at the very basic tenet, is sort of like there's the person who's then impacted by the family, who's then impacted by, oh, you got this, right? Well, it gets bigger than that. It's like 5 concentric circles. So it's the family, typically impacted by the community, then impacted by the organizations or institutions that they affiliated with, sort of schools, churches, or other faith-based institutions, then by the overall communities that they dwell in and the rules of that community or society, and then ultimately the laws that govern that society. So those 5 concentric rings. And that's the socio-ecological model. So when you start thinking about those things and addressing those upstream factors, you're now having a more comprehensive approach and thinking about equity. So we don't start addressing health just at how people behave. The choices we make are shaped by the choices we have. So I cannot eat healthy food if I cannot buy healthy food, right? So if you start at risk behaviors and you tell me to eat 5 fruits and vegetables every day, but you don't look upstream to see if they're available in my neighborhood, I can't be successful, okay? So these get to income and wealth and status. All right, population health is another term. It's part of my lingo. And I'll use that term from time to time. And the definition that I like to use for that is basically breaking people or groups up into different subgroups. That's really the easiest way to think about it, okay? And then manipulating them in some kind of way for the purposes of achieving some kind of outcome, okay? So is everybody clear on that? Okay, now why do we need an interdisciplinary or multi-sector approach? Here's why. This pie makes it probably the clearest. When we think about an interdisciplinary approach, and I'm subtly giving you parts of tomorrow's talk, there's a difference between interdisciplinary and multi-sector. Interdisciplinary is pretty much what happens here in this college, right? You've taken all of the things related to this side of the pie, the health factors, and you put them all in one college. There's still a whole another 50% that has to be addressed, okay? So that's the interdisciplinary piece, because people have health issues that require not just a physician, you've recognized that, not just a nurse, you've recognized that, not just a pharmacist in isolation, not just an occupational therapist in isolation, not just a social worker in isolation. You've recognized that. And you're thinking about interprofessional education. You're thinking about all of these things and how they work together. But still, in terms of impacting population health, it only does 50% of the population health status. There's still health factors. No matter how you think about it, there's still health factors. But if you start looking at social and economic factors, which includes things like economic and job opportunities, level of educational attainment, stable housing, transportation opportunities, that's 40%. That contributes to 40% of the population's health status. Okay? I'm not talking about Dr. Linwood's individual health status. I'm not talking about Dr. Hyder's individual health status. I'm talking about the population's health status. Those things contribute 40% of the population's health status. And then another 10 is the physical environment. So we can do this really, really, really well and still only impact 50% of the population health status. So you still have to do that multi-sector approach, which is bringing in the people who don't do the health and human service stuff, who do the education stuff, the economic development stuff, the urban planning stuff. You still have to bring them into the discussion to be able to address that other 50% of what contributes to the population health. Here's another way of looking at it in terms of how do we improve health. It's one of my favorite diagrams ever created. Thomas Frieden, who's currently the director of the Centers for Disease Control, came up with this. And he was at the time, or when he first started at the CDC, he had spent time in New York City as the commissioner there. And those of us who do this work, the work of public health is long and hard, y'all. Think of me on some days. It's longer and harder than when you're in the clinics and you cut an abscess open, you can be gratified, the patient's happy. You get a win every now and then. 3 days after they have the antibiotics and people feel better, you all win. A couple months after the blood pressure comes down, you win. Public health, it's like turning the Titanic around in a pond. It's a grueling task. So you have to step back and you say, why isn't this stuff working? And we do these things called, you do meta-analysis, you look at all the studies, you do the literature reviews, and you come up with, well, why isn't this stuff working? And so that's, in fact, what his team did, and they came up with this pyramid. And we essentially understand that what doesn't project very well in this room and in some rooms is this gradient over here on my far right, which shows you that the largest impact is at the bottom, the smallest impact is at the top. Okay, so at the base of the pyramid, where we have the largest impact, are socioeconomic factors. That's where we get the biggest bang for our buck. So, as the health director, I'm always refusing to answer this question of what one single thing could you do to improve the health of your community. I don't want to answer that question. There's no magic silver bullet. But if I had to, if you press me really, 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 really hard, I would say improve the educational attainment of the community. That would be my answer, okay? And then people look at me a little bit cross-eyed because I am not the superintendent of education. So that probably should not be my answer because that's not the job I was hired for. But I know that that would have the greatest impact. Now I can show you data. I will show you data tomorrow that shows the link between education and health. Education, health, and wealth, actually. So that's where you have the greatest impact. The next one is changing the context. You make it really hard for people to make bad decisions. This is where the school lunch conversation comes in. You all have that conversation here? Trust me, children won't starve themselves. Some of you who have them might know that, if you've been very good, resilient parents. They won't starve themselves. So if you put the choices in the school that are healthier for them, they will eat it. I know that you see on the news that people say, no, they don't eat the food, that it's not true. If you put competitive foods in there, then you're right. You know, if I can still get French fries, I'm probably not going to eat the stuff that doesn't look like anything in my house. I'm probably going to go for what's very familiar and comfortable for me. But if you put only the healthy foods in there, if you change the context where you make the healthy choice, the choice by default. There have been studies for this. If you have the stairwell in the middle of the building and it's well lit, people will use it. If it's at the end of the hallway, it requires a key pass to get in. People are afraid to get locked in it, not going to use it. Okay? So you have to make the healthy choice the easiest choice by default. Long-lasting protective interventions. So those are the types of things we have to do every now and then. We don't have to do every day of our lives. So things like immunizations. We got this whole measles debacle going on right now. It just arrived in D.C. But these are the things, you know, your kids get lots of vaccinations between 0 and 6, and they take a little break until 11 or 13. And then when you get to be my age, you just sort of get a flu shot every year. And when you get a little older, you get the pneumococcal vaccine. Once when you get 65, and then every 5 years if you keep on living. You know, those are the types of things that you, brief interventions, okay? Same thing for mammography, same thing for colonoscopy, things that you don't have to do every single day. Now, you notice we're getting higher and higher on the pyramid. These things require human people to make decisions and actively do them. So the one next to the top level, most of you, that's what you're training for. I went to medical school, learn how to be a good doctor. You come in, you have diabetes, I can prescribe something and treat that. We're interacting on a one-to-one level. Okay? The same thing at the very top, the counseling and education. It's also my nemesis, the health fair. Oh, God, I hate the health fair. I hate it. It is the most ineffective strategy ever. But everybody loves it. It makes you feel warm and fuzzy inside. You've done something for the community. You've seen them. They've seen you. It's been great. But it is the most ineffective strategy that we spend tons of money on. It only works when you directly link people to services. I mean, like a straight-up warm transfer. Like you are there with a computer, scheduling somebody with a bad result for an appointment. That's how it works. If they have you give them the result and they are left to their own vices to go follow up, they're not doing it. If they were, they wouldn't come to you for a prostate cancer screening. Like, why would they come on a Saturday morning to a stranger to get that test if they were plugged into a healthcare system? Doesn't work. It's been studied over and over again. But your nice healthcare system that sponsored it for 40 grand feels good about themselves. Think about how many studies you could get for 40 grand of whatever it is you practice for the people who are uninsured who otherwise couldn't get access to it. Better ways to spend our money. Okay, so off soapbox. Off soapbox. Okay, so counseling and education. The other thing in the counseling education box that we spend a lot of resources on is the large media campaign. That's the other one that's at the top. Your shirt is ugly. Who am I speaking to in this room? Nobody wants to volunteer for that because you all dressed yourselves this morning or your loved one picked out something and gave it to you as a gift. Same thing happens when we do the sort of eat more fruits and vegetables. Everybody thinks they're getting enough. They don't think that we're speaking to them unless, in fact, someone has given them that message directly, and just by chance, when they hear it or see it on a billboard, it might resonate with them. So again, the things at the top that require more human effort are going to have less impact. Now, please don't live here and say, Dr. Nesbitt said never have another health fair, don't do another media campaign. That's not the point. The point is we have to figure out how to allocate our resources appropriately in all of these boxes. We can't just hang out at the top of the pyramid. We have to figure out how to do effective strategies at every level. And for most problems that we are trying to solve, these things, we have to pick something at every level. I'll give you an example. if you're trying to do something around tobacco prevention, trying to reduce the smoking rate in a population, then you would say, okay, we're going to pass a comprehensive smoke-free law. The state of Michigan has one of those. When you pass a smoke-free law intended to reduce the amount of smokers in your community, it doesn't reduce it just like that. It's an addiction. People need support, okay? So you pass a law down at the bottom. Now you got to go do some things at the top. You've got to do a campaign to let people know there's resources out for them. 1-800-QUIT-NOW. You've got to let them know that number's out there and available for them. And then you've got to do some clinical intervention. Get them in there to people. Prescribe them what they need to support them while they're quitting, okay? So all of these things have to work in tandem. But the pyramid is your friend. So whenever you're trying to tackle a problem, you got to pick multiple layers of the pyramid. If you find yourself just hanging out at the top, you're not going to win. Mm-hmm. 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 Absolutely. The food pyramids we had over the past several decades were the worst things ever. Nobody understood them. And then we finally created a colorful plate, sliced it up into 4 different sections, and now everybody understands it. I mean, the images that you use to communicate to people make a huge difference in how people understand things. This hierarchy is the first time we're explaining to people that counseling and education and health care doesn't get the impact because it requires all this reliance on human behavior and people making decisions, and that we have to change the structure on how we plan to improve health by basically making it foolproof. So you have to do policy change down at the bottom where everything is just by default we become healthier people. Right. Yep. Okay. So just quickly, model practices in terms of collaboration. I think that the best way to do it, informal collaborations can be helpful. Not everything needs to be codified, bylaws, all those good things. They can work. But formal collaborations that have structure to them tend to yield better results because people feel some type of accountability and responsibility to the initiatives. One of the good model practices is the National Prevention Council. It was created as a response to the Affordable Care Act, and it is a multi-sector council. So all members of the cabinet, the president's cabinet, are part of this council, and they meet and talk about how their sector is responsible for or responsive to improving the health of our country. So they issue a report every year to talk about what their specific sector is doing to improve the health of our country. So education, commerce, defense, all of them. So just take a look at it, a glance at it, and it helps you be able to communicate to other sectors that are sort of like, I'm in public safety. What could I possibly be doing to improve health? And it gives you some ideas to just help catalyze or get conversations going with those other sectors. So I just wanted to share that with you all, and I'll give you a little bit more detail in this Louisville case study, how we did it there, because we created a version of that at the local level. So in Louisville, Kentucky, it's about 750,000 people, about 70% white, 20% African American, and then 10% other. And it is a merged city-county government. So what that means is that the mayor pretty much operates the place, and then there's 26 members of city council, so a whole lot of people. And the 26 members of city council came to be because when the board of aldermen who ran the city merged with the with the county commissioners, nobody wanted to give up their territory. So therefore you have 26 council members. And it's a Democratic government in a Republican state, although it has a Democratic governor currently. So that's sort of just the political sort of environment and the governance structure of it. Louisville also, despite being the economic engine of Kentucky, also has some of the worst health outcomes in Kentucky. 1 in 4 people smoke, 2/3 of the population is overweight or obese, high cancer above, they have cancer rate, death rates, heart disease death rates, diabetes prevalence above the national average, okay? So lots of things to focus on. In addition to that, it has high disparity gaps. Geographically, it is racially segregated, lots of disinvestment in the communities in which people of color, and then meaning African Americans and the growing immigrant and Hispanic populations live, and historical disinvestment in those communities, even though that was the original Louisville. So that's sort of the context for it. So health equity discussions abound in that city. So what we set out to do was to create an infrastructure that would allow us, LMPHW, which is our acronym for the health department there, needed a way to be able to do what we call the health in all policies approach. We really wanted to begin to have a way that whatever policy we were thinking about implementing in our community would need to look at it through a health lens. So we didn't just endeavor to solve health problems from the healthcare system side of the house or health department, what are you going to do about this, but that everybody would have to be engaged in some kind of way so we wouldn't miss any opportunities. Now, in doing so, we wanted the community to be involved. Now, disclaimer, when I say community, that does not mean marginalized populations who live in low-income neighborhoods. Community for me means anybody who doesn't work for the government. So, large employers, philanthropists, all of those people for us is what I mean when I use the term community. It's just a very generic word for me. You don't get your check from Louisville Metro government. So academic institutions, all of those fall under the banner of Community Coalition. The leadership team, because I had tried this somewhere else, the leadership team was a closed group of people who ran government agencies, had the ability to make direct recommendations to policymakers about the types of legislation that needed to be implemented, the types of changes we might need to make to our organizational policies that made the city run. What does not work well, this, trust me, is by experience, is when you have one group, not two separate ones, where the community people and the agency directors are all in one group, and the community people just yell at the agency people all the time. It's a futile relationship. I don't like to be yelled at. I don't like to be publicly embarrassed. It does not make me feel good. I don't think anybody likes that. So what we created were 2 safe spaces. And these groups interface quarterly. And because they have their safe spaces to talk badly about each other, when they come together, it is more actively to resolve issues and to effectively communicate. So they're having the opportunity to share ideas to say, okay, we've caucused in our corner and we like to recommend that you do this, and to say we've caucused in our corner and we can accept your recommendation and we'll move forward to do that. So it became a very effective communication tool, and we were able to move things forward. The criteria for the Community Coalition, as I said to you, for us, it's a very generic term. It wasn't, again, restricted to marginalized populations, and it wasn't restricted to Louisville residents. For us, it was like you needed to live there or care about there. It's a border city, so a lot of people live in southern Indiana, and we didn't want to exclude people who lived in southern Indiana but maybe worked in Louisville. So we were very open. The leadership team included all of these folks. So on a monthly basis, I held court with transportation, the police chief, the superintendent for the school system, and we talked about health policy once a month. And we did homework in between, and we got things done. So this is health in all policies. This is our collaborative approach. And health equity was our overarching theme and lens, okay? So this is looking upstream. This is a socio-ecological model. This is not a health medical model. Now, when we first started, All the hospitals showed up and they stayed engaged, but we made it very clear that this is not your thing. Like, we want you to be engaged, we want you to be involved, but this is not a hospital healthcare system thing, because we recognize that it takes more than that to improve health. And everything we do, everything we publish, that pie that shows that 10%, 40%, 30%, 20% is right there in your face all the time to remind us that this takes a multi-sector approach. Okay? So what do? I'm just going to give you one example of an issue we worked on. We got very engaged and involved around issues related to smoking. So these are our smoking trends. Louisville is the red line. So the green line is the U.S. We're above the U.S. average. 1 in 4 adults smoke. So when you're doing these kind of things, I recommend you always do an assessment of where are you currently. So where were we currently? These were our tobacco things. We got one of the lowest state tobacco taxes in the nation, only 60 cents on a pack of cigarettes. Really low. No statewide smoke-free law. We're jealous of Michigan. No state-free law, smoke-free law, but we did have a local ordinance, so that worked in our favor. We did have access to a quit line, that worked in our favor. And we had a very robust smoking cessation program that gave people nicotine replacement therapy. So those were our pluses. What did we see as area of opportunities? Well, we could definitely go up on the cost of cigarettes and tobacco products. That was an area of opportunity for us. We didn't have restrictions on smoking at public venues like the Big Four Bridge that we talked about earlier. We have a big area called 4th Street Live where people gather and they're just smoking away. You're taking in a concert outside and everybody's blowing smoke in your face. No policies related to housing. We didn't have any policies related to hookah or e-cigarettes at all. So kids could just walk into places and buy e-cigarettes to sell bubblegum flavored nicotine to your kids, basically. Okay, so this is also a process I recommend that you do. I call it key stakeholder mapping. So for each of those areas of opportunity that I identified, who are your key stakeholders? Well, the bottom line is in Kentucky, nobody can do anything about the cost of cigarettes other than the state legislature. So that's the key stakeholder there. Nothing else you can do about it. Restrictions in public venues. Well, what do we consider public venues? Metro parks, the Waterfront Development Corporation, they control a different park. It's a huge green space, Big Four Bridge, the public school system, and the Hospital Association. They want the entire health sciences campus to be smoke-free. They can control their campuses, but not the public right-of-ways in front of it. So they were considered a big key stakeholder for us. Restrictions in housing. You can smoke in apartments. And we wanted that to change. So here are all our key stakeholders for that. And then what are we going to do about this hookah stuff and these e-cigarettes? So our local legislative body became a huge partner for us, as well as the folks who enforce our current smoke-free legislation. So that's our key stakeholder map. All right, so this is just, I'm going to go through this really quickly for the sake of time because I want to get to what we can do, brainstorming around some things in Kalamazoo. Okay, so we couldn't get anywhere with the state, even though a tax commission recommended that they raise the tax to $1 and use the money to invest in the health issues in Kentucky because Kentucky's really sick. So we just decided that we'll just keep watching it and make sure whatever eventually passes, it doesn't weaken the laws we currently have in Louisville. Restrict smoking in public venues. We got our parks are going smoke-free. Can't smoke around playgrounds or playgrounds. Can't smoke at pools. The Big Four Bridge will go smoke-free in the spring. I mean, so the ball got rolling, and this was all through the leadership team. So passing these policies. So 1,100 people completed a survey, and 81% of them wanted to become law. So the public is completely on board with this. School system, completely smoke-free. Even if the kids get on the bus and they take the kids on a field trip, that's smoke-free. Where even if the place they're going to isn't smoke-free, it becomes smoke-free because the kids are there. Our multi-unit housing and our public housing is smoke-free. So all of these things began to happen as a result of the leadership team. And the private sector wanted to get involved, but they were worried about issues related to, can I evict people if they smoke in my unit? No problem. We worked with the law school. The students worked on a project, created a toolkit for us. Yeah, here it is on our website. We passed a legislation in April of 2014. We can't sell e-cigarettes to minors anymore. All that because of the leadership team. So these are the types of things that you can get done when you do the health and on-policy approach. Okay, so I asked around and said, well, what are some of the issues or concerns in Kalamazoo? So 43 out of 82 in Michigan County Health Rankings. I'm from Flint. I shudder to think where we are. Infant mortality rate is one of the highest in the country for black babies. Low birth weight and premature babies among African American populations. About 19% of Kalamazoo County's populations live at or below the poverty level. 1,000 children in school are homeless. High rates of sexually transmitted infections and limited access to care for a Mexican immigrant population. So I picked one, infant mortality, kind of because I work in this space a lot. So I can help you with that. So infant mortality. These are just your 5-year rates through 2005, because this was the most recent data I could find. And you clearly have a disparity here that needs to be addressed. Have any of you seen this data before? So some of you are familiar. Okay, this is the percentage of infant deaths due to leading causes. So the largest contribution is due to perinatal conditions. 61% is related to perinatal conditions. Majority of this is related to prematurity, low birth weight, when it starts to break down, okay? So when you look at the detailed tables behind this, and all of this is available on the Kalamazoo Department of Public Health. I'm saying the name wrong, but it's all available on their website, the detailed report. If we look at it more specifically, in this table, you start to see that the major contributor to infant mortality is low weight gain during pregnancy for the mother, which might be an indicator of access to resources. The second one is inadequate prenatal care. Next one is smoking during pregnancy. Then you have race. It's being black. Becomes the next indicator. Not being married. Teen pregnancy. Oh, not being married in a lot of communities becomes a proxy for unintended pregnancies or unplanned pregnancies. Medicaid, pay source for birth, which could be a proxy for poverty. And then again, another one which relates to access to care. So, getting back to our health impact pyramid and remembering that we have to pick things in all levels or we're not going to win, right? And so some examples, smoking cessation would be at the top. Prenatal care would be at the middle. Income and education would be at the bottom. So if you had to do some key stakeholder mapping, the line is giving you a little bit of a confusion. So the first one is restrict access to tobacco products. These are just some I picked for the sake of discussion. Restrict access to tobacco products, teen pregnancy prevention, access to prenatal care, quality perinatal health care, because it's not just good enough to have access to care. You've got to be good quality prenatal health care, and then safe sleep. So if we were thinking about doing some good stakeholder mapping, you all know your community better than I do, who your key partners and key players are. I can think of the terms generically, but how could you do this? How could you address this? How could you achieve health equity by thinking about it from the 5 different domains of the health impact pyramid? Because you got to pick something at every level to be able to win. You've got a problem with infant mortality that everything I look at for Kalamazoo tells me that's a burning hotbed issue here. You clearly have a disparity. There's a difference between health equity and health disparity. We'll talk about that tomorrow. But you have a disparity that's clearly measurable, documented through 2005. I doubt that it's changed much if there's been no concerted effort. So what could you do? Nobody wants to talk? That's okay. I'll give you some ideas. So in terms of key stakeholder mapping, in terms of restricting access to tobacco products, your elected officials could play a role in that, and your health plans. Your health plans could create programs specific for pregnant women. I've worked in communities where we've done that. We call them cute little names, the gifts program. The baby's a gift for you. We'll give a gift, you know, it's going to be a gift to you. We'll give you another gift while you're pregnant to help you quit smoking, that kind of thing. And then people get really into it. Maybe you shouldn't get them to quit smoking, but if they could decrease the number of cigarettes, because there's a difference in outcome if they smoke 11 a day versus 12 a day. I mean, so people really start delving down into how you can decrease the risk for prematurity associated with access to tobacco products during pregnancy. You can always price people out of the market. That's my best strategy. Just keep raising the price of products. Teen pregnancy prevention. Who are some of your great partners there? School system, out-of-school time service providers. Kids who are committed, who have life goals, are less likely to become pregnant. Okay? So if you have active out-of-school time providers, a host of out-of-school time programs where your kids are setting goals, lifelong goals, as early as 2nd grade, less likely to become pregnant. Okay? And there's a list, but I always love to remember that parents, these things called parents, are really, really good. When I was in Louisville working on violence prevention, one of my colleagues is a judge, and he was working on, he was a co-chair for the Criminal Justice Committee for me. And one of the great pieces of feedback we got is that when he had parents in front of him for sentencing, and they would always say, well, send me to parenting classes, or I can't go to jail, I got kids. And all of the resources for parenting classes were for infants and toddlers, and they were parenting 12-year-olds. And there were no resources for them to teach them how to parent teens who they hadn't parented because they had been in and out of jail their entire lives, right? So thinking about how do you do, what's the role for parents? How do you create effective teen pregnancy prevention programs for parents? And the access to prenatal care. Elected officials. Elected officials have a lot of responsibility, especially at the state level. Health insurance plans have to offer what is required by the state. So when you're thinking about access to care and what level of income does that trigger for women to have coverage in your state? What does that coverage include? How long does that coverage last? Does it end as soon as the baby is delivered? What does that mean for birth outcomes and perinatal outcomes as it relates to the infant? All of those things. What's the role of the health system? How do you use community health workers here? Do you use them at all? Do they play a role? Financial institutions. If people aren't planning pregnancies, they don't understand the cost of having a baby and taking it home with you. Not just having it, right? Because it might be less expensive while you're still baking it, but once it comes out, it's really expensive, especially if you don't breastfeed, right? Very expensive. So are you engaging financial institutions? Those aren't interdisciplinary partners. Those are multi-sector partners, right? So you have to begin to think of it from that perspective. Quality prenatal care. So wherever you deliver your baby, wherever you get your prenatal care, are you getting the same type of care? Is it high quality care? If you've had one baby die, don't you know the likelihood of having subsequent babies die gets higher and higher? So are people asking you those types of questions when you go in for your prenatal care? The time that you enter for prenatal care is extremely important. All of those things. So how is the healthcare system being engaged and involved in this? And then safe sleep. Elected officials. Y'all see they keep appearing. One of the other things I noticed in your community health needs assessment, housing and the availability of housing stock became an issue. If safe sleep cannot be an option for a family that lives in overcrowded spaces. So a baby cannot sleep in a crib if there is no place to put a crib. So if you have 4 people living in an efficiency or studio apartment because there is not affordable housing available for families of 4 and 5 people, that's a problem. Who can fix that? Elected officials. So you have to start thinking about these things in an upstream perspective. Your infant mortality problems cannot just be solved starting at risk behaviors. Okay? All right. So thinking about this, this is the last slide before we get to the Twitter page. And it says, so when resources are scarce, it's best to prioritize interventions and allocate resources to high-impact areas. Okay? So I know times are hard. We don't have a lot of money. We got a lot of smart people. And a lot of these interventions that are necessary to improve the health of the community, I'm a firm believer, don't take a lot of new money. It takes us spending the money we have in a smarter way, okay? And then the population impact of an intervention increases. The likelihood it's going to be successful is going to increase the less we rely on individual effort. That's extremely important for you to remember, okay? And then anytime you're working together as a collaborative, you got to remember to establish some shared metrics for success. That'll keep the partnership going. So when you have your own space that you work in occupational therapy, or your own space that you work in nursing, you're going to have your goals specific to you, but you got to have some shared metrics that are higher up for the partnership to keep you all going, because you can share in the achievement of those global benchmarks or those global metrics. And so that'll be your motivation to keep partnering with each other and staying in the fight together, as opposed to retreating to your own individual silos and just achieving in your own space, in your own domain. So coming together and establishing those higher level group benchmarks that you all can agree upon and then work to is going to be extremely important. All right, so that's it for me. Any questions? Thank you. I think you have to use this so they can hear you.
The question I have is, we kind of talk about systems approach and take financials out. We know a lot of things about how communities should go together, more integrated and so on, but it's not happening. So a lot of things you're talking about, it's been around for a while, so it's not necessarily rocket science, but the motivation to get people actually doing it always seems to be the sticking point.
I did not plant him here, but that was my favorite question. So this gives me the opportunity to give my analogy of why people get stuck. And a lot of times people get stuck because when you get in the room to establish your shared metric, you all kind of say, well, we need to focus on that one thing, and you want it to be this nice, pretty, uniform circle where everybody's going to all fit nicely together in this one perfect way. And I think that is the recipe for disaster. It makes me cringe. You're not all going to agree in that way. I think if you look at it as these strategies or these approaches that we need to address any problem should be viewed more as a mosaic, a nice, pretty tile mosaic, where some of you will overlap and work together. Some of you will never overlap. Some of you will overlap on some issues. Some of you will overlap on other issues. That is the best way to think of a collaborative. Once you get into the phase of embracing it in that way, you'll get stuck less, because you'll recognize that it's okay if this group doesn't show up for this particular issue. It doesn't mean that they've abandoned the collaborative. It means that this isn't their thing. Because once you start pushing everybody to always want to work on everything, now you're talking about messing with my mission, which means you're messing with my budget. You're messing with my staff's responsibilities. You know what I'm saying? We're in a different ball game. We started to think about it in our population health work as something called network leadership, primarily because the way that we are structured to think in organizational culture, everything is a hierarchy and domain. Y'all have a dean, and there's maybe some associate deans and assistant deans, and then tenured professors and associate professors and assistant professors and maybe clinical instructors. It all works perfectly. You understand how you fit in here. It works. When you get into collaborative, all bets are off. And in our community coalition, by day you are a church clerk and by day you are a CEO. When you come into the community coalition, you're here. And that's a very different concept and construct that people have to begin to recognize and have to begin to operate in. And so you have to set those ground rules early. But I think the biggest failure is everybody wants to think that everybody's going to always align. Organizations 1, 2, 3, ABC are always going to be at every single table doing every single thing together, and I don't think that that's realistic by any stretch of the imagination for any community. What you have to be committed to is working on health equity. Now, as the issues you select or the policies that you select arise, the different players may become interchangeable, and that's okay. It makes a beautiful mosaic at the end of the day. You'll get less stuck there.
Thank you, Dr. Nesbitt. One of the things that just is still a reality is that when we're trying to deal with elected officials, they too have, as you have said, their mission.
Yep.
So I'm not sure I'm going to convince the mayors or the governor of the state of Michigan or Indiana or Kentucky that, you know, this is the thing that they need to attend to. Oh, well, if I can put it in the term of income, possibly I can, but still, that's a long-term sell. I'm going to get that baby from the ovens to being a productive, tax-paying citizen in this in this state. And so I would say, is there a trick to that? Are there things that are? I mean, everybody loves health and babies and all that good stuff, but it's a joke a lot of times because that is not where our elected officials are worrying about. They're worrying about the pipeline that's going in with the oil that's going across, or how we're going to get more manufacturing into the state of Michigan, or a lot of other things that are seen as very, very, very important in the eyes of officials.
Question number one, yes, there is a trick to it. Number two, your elected officials become very interested in the things that your philanthropists and your foundations are interested in. And all of your philanthropists and foundations love babies. They do. They all love babies. So I'll answer the question in terms of, is there a trick to it? These views are the views of me. They are not the views of my previous or future employers. And so I got to let's put that slide back up there, number two. Because now I'm teaching a policy class. That's the other thing that I like to do that's really fun. So the trick to it is that you don't know how to do it, but economists, political sciences, and political strategies know how to do it, and they should be part of your multi-sector team. Much work has been done about the cost of sick babies on our society, right? And much work has been done about how productive an individual can be and what their contributions are over time if they become a taxpayer versus how much they cost us if they don't. So you beginning to use that and juxtaposing it against each other becomes a winning tool for you. The part of the successful tips for tomorrow is know why your partners do what they do and decide how you feel about it. So there becomes this, you have to get out of this space of always wanting people to do what they do because you do what you do for the reasons you do it. And you've got to figure out how you feel about that. Some people can feel comfortable, some people can't. But you've got to decide how it works for you. That's the trick to it. I'm not an economist. It's not what I do, but I have some good friends who are, okay? And so I learn how to speak their language as far as it gets me in the door, and then I drag them in with me with their good information. And so that helps to communicate. The second thing is philanthropists and foundations waste a whole lot of money, and they give it to people who have a better dog and pony show than many of you have, and that's the problem. They don't invest in evidence-based strategies. You're sitting here doing all your great research. You got all the good evidence, but you don't have a good show at all, and that's the problem. And so one of the things that we were able to do was to start hosting what we call funding forums and convince our foundations locally, please don't spend any more money until we tell you it's okay. Seriously. And they were like, oh, okay, okay. And then some of them still do, but then some of them are saying, well, we got this interesting application, or we're thinking about funding in this domain, but what we had to take seriously as our responsibility was to start publishing more reports, putting out there what we thought were evidence-based practices, start saying these are the areas of pockets of concern, start geomapping more. I mean, we had to give them more tools to make better decisions. But you can't necessarily say, we want to work on violence prevention and then walk away. You have to say, we want to work on violence prevention. This is the framework that we are using. We want to host a funding forum. This is the direction that we want to go in. These are the needs that we have as a community. If you're going to fund in this area, please consider these things. And they will do it. Your foundations and philanthropies in your community will do it. They want to improve outcomes as much as you do. But if you're not giving them a framework, if you're not giving them a roadmap, they're left to their own devices. And when people come with good stories, they'll invest in them. They'll invest in them. A lot of the ideas that people have are not intentionally harmful, but we have to get out of seeing a problem, coming up with a solution, and assuming it will work, but getting more into saying, these are the demographics of our community. This has worked in a community with similar demographics. Let's try that here on a small scale, demonstrate that it works, and get the resources to bring it to scale. And you all have to be responsible for brokering those types of relationships. Otherwise, you get what you get. But foundations don't want to be left to do this alone. But they have to spend their money if they're a foundation by law. They have to give it away by law. Yes.
Hi, I'm Rashonda Jones, and I'm a social worker, but I'm also a teacher. And Kalamazoo is known for their education community. And so we rallied around education, and we have a lot of service providers in education who also care about public health. But how can we get the two sectors to come together? There are a lot of people who put money into different programs, like there's a nurse-family partnership, there's Healthy Baby, Healthy Start, and other things that they are good, but they may not be as effective at the time the programs that you're talking about. How do we get the community as a whole to rally around this infant mortality thing or health equity in a way that we can make it a community thing and not just individual organizations?
Yeah, well, one of the things when you're doing this sort of assessment, if you think about the Louisville case study, you always want to start with, well, what do we have currently available to us? So if you're thinking about the programs that you described, which are home visiting services and programs, you kind of outline what are the restrictions or what are the service areas for those particular programs. So nurse-family partnership is restricted to first-time moms. You have to get in the program at a certain period of time. So you can't be too far along in your pregnancy before you get into the program. So there, based on the data that I showed you, in that your infant mortality problem is spurred by people who have inadequate prenatal care, there's still a segment of your population that program won't serve because they won't meet program criteria. So I've quickly, as you tell me you have nurse-family partnership, I've identified a gap that still exists in home visitation programs for you. So when you're doing your analysis of what still needs to be brought to bear in your community, home visitation programs are highly effective strategies for infant mortality reduction, and there are other models out there that will serve kids from 0 to 2, 0 to 3, 0 to 3, and then another model will pick up from 3 to 5. And these are all very effective programs for early childhood development. So you have to sort of map these things out and say, what do we have and what do we still need to build? And putting all of that together is going to be part of your solution. Now, you don't have to get rid of nurse-family partnership, but you can't have that and think that that's sufficient because it doesn't meet what's still your problem. So doing that kind of analysis is going to be very critical.
Please join me again in thanking Dr. Nesbitt for